and by prolonged use of steroids. Surgical approach is quite different and quite challenging than the conventional ones. As already been told, pre-operative management starts right in the OPD with detailed slit lamp examination before and after dilatation. We must aim at complete control of intraocular inflammation minimum 3 months before we plan to do surgery. Start steroids the way they are indicated, maybe topical or oral, and NSAIDs in all cases. Anesthetics, antivirals, if there is coexisting glaucoma, let it be tackled separately, and if there are posterior segment complications, they may be tackled together. Surgical management has got one basic principle, that is to maintain the anatomy of anterior segment structures. So for all this, phaco is the only choice, and the biggest challenge is a small or festooned pupil. And how to tackle it is the whole game that revolves around managing cataract in uveitis patients. Difficulties of small pupil we all know. They start from inadequate view, they prolapse from the incisions, and there's capsular damage. Rhexis is difficult and incomplete evacuation of the lens matter and cortical matter. Management options start right with full dilatation with tropicamide, phenylephrine, and NSAIDs. Intracameral matrices should always be tried with adrenaline and phenylephrine also if available, and Zalcard. And then the stepwise try snicolysis, peel off any fibrinous or pupillary membranes. We may need to do stretching or sphincterotomies or the newer devices which expand the pupil. Now I'll be showing you a membrane peeling. This is a membrane which is being peeled with Jutrata, and left hand is giving counter traction to ovoid arteriolysis. Just by peeling the membrane, our pupil gets dilated, and many times we can manage just with this much of dilatation. And this is again the next step in which I'll be showing stretching. We try to peel off any pupillary membranes, do the snicolysis in all the cases, then assess the size. In case it is inadequate, then we can do stretching by inserting 2 Y-hooks from 2 opposite sides, then repeating the maneuver at 90 degree apart. Then assess, can we go ahead or still we need to do something? In case we can go ahead, we should, otherwise I think we can go ahead. Disadvantages of these stretching we all know. They leave a dilated atonic pupil, chronically inflamed and photophobic. And dilating devices or expanding devices include hooks and all sorts of rings we'll be showing you. Hooks are very common these days. They are really freely available, easy to manipulate, and can be utilized to anchor the rhexis also sometimes if need be along with iris. Disadvantage is also very clear. They also, like stretching, they also bleed sometimes, leave an atonic pupil postoperatively, and need many entries. Leakage even from one of those can lead to shallow AC, and sometimes we find the field is very messy. And these become the advantages of rings. They do not need any separate entry. They dilate as well as stabilize and create a round rather than square pupillary opening and lesser trauma to the iris comparatively. And we can make the rhexis of our desire. These are the various types of rings that are available, starting with Mulligan, eye ring, Gupta ring, expanders, Hexa ring. This here I'll be showing Mulligan ring, which is a very popular ring these days, and it should be used by one and all. First we do snicolysis, and then try to peel off any pupillary membrane. Then we load the ring. Ring is made of 4 eyes connected with 4 arms. These arms control the iris and eyes engage the pupil. Left hand is guiding, left hand spatula is guiding. The leading eye engages at 6 o'clock and lateral eyes engage at 3 and 9 o'clock. and the trailing eye is engaged with a hook or with the same spatula. Look, this is our axis of Earth. We can do whatever we want in this size. Look at the size of the pupil that was before and what it is now. And similarly easy to disengage. Disengage the trailing one and just pull out, and they all come very easy. So the job is done. We find a good size pupil at the end. This is how we put Millikan's ring. This is an eye ring. This is a bulkier ring with very thick arms. We load it in the plunger right from the stand, and little more difficult to insert than Millikan ring, but once inserted, this keeps the contents of anterior chamber in a much better position, and we can manipulate and we can operate at comparatively greater ease. But it's a little difficult to put. These are all expensive gadgets, but they're very beneficial to the patients. Look, it's been done. This is a different ring. Special feature is that it is made in India. And least expensive, costing a few $100. Single wire, very thin wire, coiled at 4 angles. This is loaded into an ordinary Indian lens injector. We'll be loading it and inject just like any other ring. This is more little difficult to put because it's very thin. This is a case of post-keratoplasty uveitis induced cataract. Similarly, we do sneakolysis and then assess. Remove the membrane. If we find it's good enough, we go ahead. If not, then we adopt other measures. Here, since it was a case of keratoplasty, we wanted to be very sure that we don't touch anything else. Similarly, ring is injected and the eyes are engaging the iris at different points. And trailing eye can be engaged with the help of Wyszynski also. Look, so a simple ring has given us a very good view of the pupil. We can operate with full clarity. Ring is in place. We got it. Comparatively, pupil is a little squarer here, but it works well. After the case, we simply disengage Wyszynski and just pull it out. Single use ring costing just a few ₹100, and very important these days, made in India. Well, now come to phacoemulsification when we don't have any ring or we don't do any ring. Make your tunnels deep enough. Main tunnel, side ports. Try to make 2 tunnels in such cases. And make your axis about 5 mm. 2 smaller axes can cause phimosis and decentration, especially in such cases, and 2 large ones also are difficult. They also cause dislocation of the lens and cause posterior formation. Settings should be of low energy, high vacuum, high flow rate, so that we don't have to go fishing for the matter here and there. So just after gentle rotation, stay in the center, send direct chop right in the capsule, works, that's it. And this is a 4 mm pupil, but with the dexterity, we can go ahead. Just remember, we will not go out of the pupil and flow will be very high and job is done. That's it. This is also another small pupil, festooned typical. I make my blind pouch, blind tunnel, then the main tunnel, stain it well, remove the membrane, break the synechia, and look, sometimes just breaking the synechia and removing the membrane leaves behind a very good and well dilated pupil. And cataract behind is pretty hard, but let's do that. I think we can manage with simple membrane peeling and sneakolysis was enough to handle in this case. Again, our chop has to be central, direct chop. We cannot fish out in the periphery, and we can finish very well. A pupil which was looking so bad at the very start, at the end of the case, it becomes as if patient was very good and very normal. So, job is done. Now, post-operative management, this is as important. Patient, especially the first 2 weeks, patient must be kept on heavy dose of steroids, topical, oral also if need be, antibiotics, ointment, and Mydriatics, also short-term mydriatics to avoid synecdoche. Oral steroids, if were given in the pre-op period, should be maintained at a target dose for a week or more before being tapered. And systemic antivirals, if were given, should be continued at a target dose before being maintained at a prophylactic dose for a couple of weeks. Well, expect complications. They are going to happen. Post-op intraocular inflammation is the most feared one. It starts right from AC cells to membranes to hypopyon. Steroids are the sheet anchor. Increase the dose. Sometimes even membrane removal has to be attempted after controlling the inflammation. In case of uveitis, be ready for oral steroids and injectables or vitrectomies as required. CME is also quite possible and it should be treated with steroids and NSAIDs, ERMs. At a later stage, they may need delimitation depending on the visual status of the patient if need be. Well, PCO is pretty common, up to 50%. We should attempt YAG only after controlling inflammation because of the high risk of post-YAG CME. And IOP spikes, like normal cases, are to be expected here, but they are usually transient. Avoid prostaglandins and alpha-adrenergics. Hypotony is a surgeon's greatest fear. After ruling out only increased anti-inflammatory therapy, the topical steroids may need to be continued for a pretty long time. Take-home message in the end is very, very good detailed pre-op counseling. Sit with the patient 10 to 15 minutes. Talk to him detailed. Give him the full prognosis in detail. Tell him the likely complications. Tell him even those complications you haven't ever seen. Tell him everything. Good pre-op control of inflammation. And do not struggle with small pupil. Take the help of these newer devices, rings, hooks. And if none of these is available, pupil stretching with sphincterectomies can be done. Do expect complications and be ready to manage them. You will be able to. Once we are fully armed and approach is systematic, a result is a very happy patient in most of the situations. Thank you so much.